passionate about what's happening in the county and just ensuring that our residents have access to quality care. Thanks for reading my brief bio. I spent over a decade as a scientist, a PI, born and raised in the District of Columbia, then later moved to Prince George's County, and was brought
Well, I'm
on by
thinking
the Board
about
of Health.
stopping training for muscle growth and start only training for
I'm going to make sure
maintenance.
everyone,
Yeah.
please mute your, thank you.
Yes, I was recently brought on by the Board of Health with the new council um, to work with the Board of Health in helping them strive towards building healthier communities. The Board of Health is a body that works closely with the Department of Health, and I was giving tasks, deliverables to strategically work closely with sister agencies and other health institutions to bridge the gap in where we're failing as a community. So much has happened. I don't even think we can get through it, but all great things. The first initiative that we are tackling is the nurse to patient ratio, the emergency department wait times, and also behavioral and mental health. I am so passionate about this. Being a healthcare advocate, this speaks to my heart and my soul. So what we've done, we've worked closely with the county executive office. We just had a meeting. Let me just tell what I did. I conducted epidemiological data and trends in each council district to see where the gap is. Are we meeting the residents' needs? Do we have the physicians ready and available to tackle these comorbidities, these diseases that are affecting our community? So what we did find out is we do not have that, but it's okay. We have a plan. Yesterday we met with the representatives, the delegates on a state level down in Annapolis that presented us a plan where they have mandates and laws that they're putting in place that align with all the discrepancies that I have found. So that gives me hope that we have a progress, we have a plan that we're working towards bridging the gap, building healthier communities, getting more beds, and we're getting more beds in these hospitals and getting standing mental health facilities to help vulnerable populations. We're doing excellent work. I am driven by data, and I am ensuring that my team and I are gathering data not on a countywide spectrum, but on a district wide spectrum. Why is that important? Because every district is different and have different needs. So we want to assure the correct message is given to you, the Board of Health, where they can take to the health department and we can build programs that will work for the community. And not only that, we're focusing on primary prevention strategies that will help combat these diseases. To be specific with you, hypertension, blood pressure, and cardiovascular, and maternal health are some of the deliverables that my team and I are working with to build programs, work with these hospitals, and just bridge the gap. I know I've said that many times, but it's so many gaps to be bridged, and we're just passionate. We're getting things done. And today at 1:30 earlier, there was a hearing, a testifying hearing at the council for emergency room wait times. So I have relationships with presidents of hospitals. I work closely with Adventist Hospital and Luminous, and they were there to support this bill. And as I mentioned yesterday, I met with the people who are really able to get the funding in the county and make these laws. And they were very receptive to my analysis, my recommendations. So we will be working really close with the state level. And lastly, November the 6th or the 7th, I have my dates mixed up, we're having a mental health town hall where we're calling in the Department of Health. We're calling in these hospitals. We want to know what's being done. We want to know what standard operation procedures they have in place what protocols that they're implementing for change. So I came in with the mission, and my mission was to build healthier communities from science to service, and we're doing exactly that.
Thank you so much.
I think I gave you all a earful.
No,
It's just a passion.
thank you so much. Does anyone have any questions for today? And I believe we're expecting Dr. Blocker as her time is as she's available to be able to join these meetings moving forward to provide some updates. So
I
we'll have more
definitely will do
opportunities.
everything. Every time that you have one, I will do my best to be there because we plan to have updates on a monthly basis.
Excellent. And if there's anything that the group can do in terms of reaching the community or supporting county council or providing feedback, we are here exactly for that.
I do have a question for you all. If you can just give me maybe a brief background on your mission, your vision, and what you all are doing.
Absolutely. So right now I'm going to actually go back because we have our vision page here. So our vision is that Prince George's County is a place where everyone has equitable access to achieve their full health and wellness potential, regardless of race, color, religion, county of origin, country of origin, immigration status, class, age, disability, sexual orientation, gender identity, or health literacy skills. So as a group, we are just working on initiatives to make sure that we can address health equity within the county. So the coalition's role is to help complete the community health assessment every 3 years, along with the county hospitals. And then we take that health assessment and identify the priorities within the county. So we've identified ours as social determinants of health, which we address in the health equity work group, along with metabolic syndrome, obesity, and behavioral health or mental health. So we have 2 separate work groups that focus on behavioral health and our healthy eating and active living work group to focus on metabolic syndrome. But here within the health equity work group, we've been doing some strategies focused on boosting health in all policies. We've been focusing on our health equity champions curriculum, which will be a educational program to foster health equity champions and have more people to have a voice for health equity in policy decisions or all decisions throughout the county. And I know Dr. Slade Martin's out of a voice, but I'm doing my best to try to relay these initiatives. We also just want to serve as, an advocacy group for the county for health equity, whether it be by providing feedback for policies or programs that are ongoing to make sure that they're addressing health equity appropriately. So that's kind of the nutshell of our work group's goals. And then we're still, of course, we have just ongoing taking feedback from all of our community partners to address any new strategies that are identified. If anyone else with some background wants to jump in, feel free to give a little bit more insight. Thank you, Dr. Slade Martin. Yes. Okay. So so that's a little bit about our work group. We're constantly just trying to build support and really just maintain communication with all of our stakeholders who are looking out for the community.
Awesome. Sounds great. Thank you all for your work and your advocacy.
Thank you. And I will give one last time and one last chance for any questions today. Yes, I see Sharon Zaluski.
Yeah, I'm sorry. I just wanted to raise my hand and comment on some of the work that we've done that might be of interest and provide some background. We have 2 papers on our website. One is on the impact of structural racism on health. The other is on immigration status and health. And both of them are focused on Prince George's County and how over time people are impacted by policies, and their health is impacted. And the other thing is we worked diligently on passing a health equity, health and all policy bill a couple of years ago, which I don't believe has been implemented. It had to do with holding county contractors accountable, and the county itself accountable for developing a health equity plan. So some of it may have been implemented and other pieces of it weren't, but I just wanted to call your attention to that. It was sponsored by, see, somebody leaves and you forget their names immediately. College Park, she represented College, Danielle Glaros. Sorry, don't tell her I did that. But that's something also to look at as perhaps something to revisit and not have to redo some of the work that has already been done.
Awesome. Thank you for that. Thank you very much.
Yes, thanks, Sharon. Does anyone else have any comments or feedback? And thanks, Christine, for putting that in the chat. All right. Hearing no further questions for today, everyone feel free to think of some more questions over the next month, and we can follow up with Dr. Blocker then.
Sounds great. It's a pleasure. I'm grateful and I'm blessed. And I continue to do this very important work and collaborate with you all as needed.
Thank you so much.
All right. Have a good one and take care.
You too. Bye. Thanks so much.
Bye-bye. Oh, Dr. Katie. Okay.
All right. And I will take this opportunity to introduce our next speaker today, Dr. Kate McFall. Dr. McFall is an occupational and public health researcher, educator, and specialist with demonstrated COVID-19 experience, protecting workers, setting up COVID-19 contact tracing, and return to work systems. She has worked in academia and the federal government and is currently the editor-in-chief of the Workplace Health and Safety Journal. So I welcome Dr. McFall.
Thank you. Thank you so much. I look forward to getting to know everybody. What I want to talk about today is a community-based participatory research effort called Care About Your Air. And part of what we want to do is put this on your radar screen as an equity group. We are doing research on the relationship between indoor air and human health. But our part of the research, or my part of the research, in collaboration with Dr. Bauer, who's also on the group, is about how best to talk to communities about the relationship between indoor air and health, and some of the ways that air can be cleaned, if you will. So next slide. Basically, it's a formative research project, which means we don't know what we don't know, right? And we're just basically asking questions, and we figure that the community is the best place to ask those questions, especially when it comes down to creating messaging materials and educational materials about the role of indoor air in human health. So we do know that, we know that there is a relationship between what's floating in the air and human health. But what we don't really know or understand is that everyone from clinicians and healthcare professionals and community members don't have a great way to get a handle around indoor air. And problematically, it's also invisible. So people don't think about it that much. So the design for the research is community-based and participatory, meaning that we hope to develop relationships with partners such as your group. And much of the research is qualitative in nature, meaning we're doing interviews and focus groups and really trying to drill down to all the contours and parameters of people's understanding, their concerns, what's more important, what's less important, and if they were approached with a process for thinking about indoor air, what would be the best way to do that? Next slide. So our context here is a large context. I mean, part of what we feel like is that during the pandemic, there were many communities that were sort of left out of really good messaging. There were problems with messaging and education. There was evolving science. And all of this is potentially a problem with indoor air as well. But one of the things about indoor air is we feel like it was not used to the in the most effective way during the pandemic. So for example, some of the technologies that we'll be talking about and researching would be good to have in place for the next pandemic, for example, because they may be one of the few ways we can make air and indoor spaces safe before a vaccine is developed. But there are other utilizations for this as well, including homes and people who have asthma and a lot of other things that can happen to the air, and people spend a lot of time inside. So one of the reasons that even though we need to take sort of big picture approaches to policies around particularly public indoor spaces, schools and workplaces, public buildings, restaurants, we want to do this with a sense of what the community needs and wants. And of course, we'll ultimately get to the data, and this is absolutely a research study. Next slide, please. So we are a branch of environmental health, and that is where my faculty appointment is in the School of Public Health. I'm part of the environmental health group. So much as you have information around your air quality in terms of outside air, you can see various numbers showing up in your weather reports, and same with safe drinking water. Your drinking water numbers come through the water department, monthly or quarterly. We have laws around food safety and other types of safety. This world, indoor air quality, is just gaining a lot more attention since the pandemic, although it's been around for a while. Next slide, please. So the elements of clean indoor air are these, and as you can tell, these are long, many-syllable words that people might start to glass over. Their eyes might start to glass over when you're asking them to think about their clean indoor air or their air, which is invisible, and then you start going on and talking about ventilation and air filtration, and then you want to talk about germicidal ultraviolet light, which is something we do want to help people understand. So these concepts can seem intimidating and can seem complicated. And we're in the business with this study to try to bring this up to people, lift up their understanding around these concepts, and find out from them who are your credible messengers, who are the people they want to hear information from. So as a very concrete example, say the county decides they want to put new technology into schools or into emergency room waiting areas, which is not a bad idea. These are places where there can be a lot of viruses and pathogens in indoor air. And yet if they start to talk about things they're doing around ventilation, air filtration, or germicidal UV lights, people might be concerned. They might have a lot of questions, or they might get left out of the conversation entirely. So the idea behind our work is to try to empower people with enough information and resources to ask questions. If you're a parent in a school, if you're somebody that's, visiting a healthcare facility, you may want to ask these questions, even a library or a restaurant. Next slide, please. So this is kind of a picture. It might help it make more sense. So if you can see, the person on the left in this case is someone that's sick with COVID, and there's a lot of dots around them, and that's kind of depicting the virus moving through the space. And a number of different ways can make those virus particles either go away, like be diluted through fresh air, or be captured, like through filtration, or this technology that I've been alluding to, germicidal UV light, can actually kill the germs in the air. And of course, then they're not there at all to infect people. So this technology is something that everybody will probably want to think about and understand, especially if it starts to be available in our common spaces, and you want to sort of make decisions. Do I want access to this? Do I not want access to this? The most important thing is to understand it and to feel empowered to ask questions and do something. Next slide, please. So this is the way the project works. We are looking at a lot of sources of information. We've done website reviews of what the federal government tells us about this issue. We're partnering with communities and getting communities and organizations to spend time with us and review materials. We're message testing. We're doing key informant interviews and focus groups that are stratified by literacy, culture, geography, ethnicity, because we want to understand if there's a variety of opinions around the best way to educate on this issue. In the lower left-hand corner is a room at the University of Maryland that used germicidal UV lights. And basically, we are trying to make sure that the information we produce makes sense to people and they feel like they can use it and that they can understand it and they can do something with that information. So we're trying to figure out who are the trusted messengers in various communities in order to push information out. Next slide, please. So I'm just about finished. Basically, some of the principles that we're working with, especially on the heels of the pandemic, is to try to avoid the avoidable, make sure our messages are clear, that we're addressing them to people where they are, so they don't have to stretch or feel, not respected as we do our messaging. We do want to respect our communities. We don't want to dismiss, intimidate, or confuse. We are trying to establish true partnerships via advisory groups and partnership groups and our qualitative research methods. We want to educate. We want to teach diverse communities and be partners with them and be transparent and be honest. So we're trying to cultivate trust with the communities, and this is something that we want your help with also. We'd like to partner with organizations that are part of the Health Equity Workgroup. Next slide, please. So partnering with us may involve participating in key informant interviews. We're looking for community and business leaders and identifying groups that might be willing focus group participants within communities. These can be geographic, they can be cultural, they can be church communities, and ultimately give us feedback on the messages, on the educational materials, which is going to include at some point website, video, all of that. next slide. The last slide is basically my contact information, which you can also get through Kim and through the work group. So I really appreciate your time, and I'm happy to take questions. And I hope it wasn't confusing because we're working on talking about this.
Does anyone have any questions? I see Dr. Slade Martin put in the chat that faith leaders, civic organizations are seen as trusted messengers.
Absolutely. We are currently working kind of rural focus at this point. We're down in St. Mary's County in Southern Maryland, and we're absolutely talking to pastors and churches. Churches had a tremendous time during COVID trying to figure out whether to worship in person and how to do that safely. And of course, they were such a critical part of mental health and addressing social isolation, that's a particular favorite of mine, is to work with the churches and worship communities. I'm still getting calls from people that are just coming back into worshiping together.
I had a question. I think that when the first thing that some people think of when they see technology enhancements is dollar signs. Do you have any thoughts on how we can ensure an equitable rollout of these kind of technology upgrades in either public or private settings?
Well, I think it begins with people understanding it and not being fearful of it, so that, the bedrock principles of health equity are sort of accurate information and information that you can use. So it's accessible, you can find it, and then you can do something with it. And I'm actually envisioning having clinical people begin to ask questions of parents and people who are employed, asking them about what they understand and know about the area that they work in or live in or go to school in. And I think that will start to push the envelope. I think that in some communities, healthcare providers are also trusted messengers. Yet in this case, healthcare providers often don't know anything about this. So it doesn't help you to go ask your doctor, how much fresh air should be in my home? What sort of filters should I use? Is this germicidal UV technology going to hurt me? Because your doctor won't know. So we've got to raise a lot of boats kind of simultaneously. We'd like to partner particularly with health departments, which is why Kim, the Prince George's Action Coalition is super helpful. We're with the same group in St. Mary's County. And also our library systems. We're anxious to work with our library systems because sometimes that's the only place you can go to get to a computer and you can get some great information. And so I'm super excited about working with librarians and library systems. But I think it's a matter of people being, understanding it. Then, of course, you've got to organize like you always have to do. And ultimately, there may have to be some regulations because you may start to see certain schools in certain communities or certain public buildings have access to this technology if they can afford it. So we understand through the COVID infrastructure money that there is a lot of money for air infrastructure, indoor air infrastructure that has not been spent. And so it's being spent probably in the state, and some schools unfortunately are doing things that don't make a ton of sense, and some things are doing, some schools are potentially going to put in systems that do make a lot of sense. And I think it depends on the communities being engaged and being interested and advocating for what they want in their buildings. So that's a great question. It's a huge undertaking, we will be doing this probably for many years to come.
Does anyone else have questions or feedback?
Feedback is great, is definitely welcome. And that's why I'm so glad you kept my email up there as long as you have, Kim, because I can hear from anybody at any point. And we'd like to attend these meetings. I have Michelle Blanc on the line with us, who's part of our staff. And we'd like to partner with the Health Equity Work Group.
Excellent. I'm seeing another question from Sharon Zalewski. Is there any effort to exploring air quality in public housing and the shelter system, especially when there is a new construction or older buildings being retrofitted?
Well, so in both of those situations, new construction and retrofits is actually the best time to for informed constituents to bring this forward. And the Centers for Disease Control has now come out with some guidance around ventilation principles for health. So most of the regulations that are out there and the codes that buildings have been built for are for comfort. So they're warm enough, or they're cool enough, or they have a certain level of humidity. And so you feel comfortable when you're in there. But we're now starting to see code changes for health, particularly around infectious diseases. But this could also include allergens and chemicals and other things that can be in your air that you don't know about. So inside homes, for example, we now know that gas stoves can be problematic for health. And so I think for public housing and other residential situations, multifamily buildings, the ideal time to get involved with that is retrofits and new construction. But there are many things that can be done and tested and monitored even with existing buildings. But there's like a lot of information that or what I think is really most helpful for people is to help them understand the CDC guidance and how to ask the question. So you don't have to be an HVAC specialist or an engineer, but you could say, this is what CDC is saying. For example, 5 air changes an hour of fresh air is recommended. So basically you ask the question, can this building do that? Am I getting that in this room? Am I getting that in my office? Am I getting that in my apartment? And that's what I think we need to help consumers and the public understand, is how to ask the questions and then how to report problems.
Christine, did you have a hand up?
Yes, I did, and I may have missed it, Dr. McFall. Is the area that you're focused on, is it only Maryland, or are you looking regionally?
We have the latitude to go elsewhere. We're focusing on Maryland because we can, within an hour or two drive, get very rural, low density populations. We, of course, want to do Prince George's County because we're located right here, and we want there to be value added for partnering with University of Maryland School of Public Health. And we're probably going to be in Baltimore City, but we could also go into Washington, D.C. And we would go elsewhere. It kind of depends on the situation. We have at least another year's worth of funding to keep doing this and parlay it into something that's a little bit more of a program rather than a research study.
And I asked because I have a colleague that works with the DC Healthy Housing Coalition. So, and this seems like it would be something that they may be interested in.
Yeah, I think that's a definitely an appropriate and eligible organization to work with us. And what we try to do is, if we do something like that, we then try to do something similar in the rural location and in the suburban location. And that could potentially be, our urban element. So that's kind of what we're doing with libraries and, health action coalitions, and clinics and that kind of thing. So I would appreciate maybe finding a way to communicate with you, or you emailing me, and we can talk more about that. Thank you.
And when oh, go ahead.
I was just going to say there was something interesting or some feedback I think that came through the chat, but I haven't had a chance to open it up yet. Go ahead.
Oh, I see Dr. Slade Martins has said in the chat, when talking to the community, using examples like the impact of gas stoves would likely draw a lot of interest.
Yeah, I agree. And that's a great comment. I know people first and foremost are concerned about their homes and their children and their elderly relatives. And I should add that long-term care and congregate living situations are other places that we're very interested in, especially the elderly, but the little ones too. I mean, daycares are another situation where there's a lot of coughing, hacking, germs. Some of this technology can actually be used to disinfect surfaces. And so that's a lot. Actually, our schools in Prince George's County are using that right now. They're not using it for the air yet, but they are using it on surfaces so they can completely clean out classrooms overnight before the students come back in, and not have to use cleaning chemicals to do it. But it's kind of nice to know, and it's kind of nice to understand it, especially if you have a child in the school.
Yes, and to the point you just made, we do have some representatives from the daycare facilities throughout the county that we worked with through COVID, as well as the ombudsman for the long-term care facilities, who could probably help you get some focus group participants from that side.
Well, thank you. I would really, those are community groups that are very important, I think, to this effort. That would be lovely. And of course, I'm more than willing to come back and report on our progress. We've made a lot more progress in St. Mary's County, but we're just now starting to do our work in Prince George's County. So we can keep you posted on what we do and what we find. And, when we get our website stood up, share that with you as well.
Excellent. Thank you so much. Does anyone have any final questions? All right, seeing none. Thank you, Dr. McFall. This was
I appreciate it.
Very interesting work, and I look forward to hearing more about it.
Thank you.
All right, we will go ahead and transition. So to give a little bit of recap from our last meeting, we spoke about the Health Equity Champions program and ways that we would implement this program. So meeting with the co-chairs, we felt that the work that we need to put together, it requires a little bit more focused attention. So in order to give a little bit more focused attention to this Champions program, we propose developing a subcommittee to take the lead on the content editing and program implementation decisions. So some of our next steps to make moves with that subcommittee work would be to identify subcommittee leadership and then engage participants to be a part of that group. And then finally define whether we want to use health equity work group time, or if we specifically want to meet as a separate group and report back to the health equity work group. So with that, I want to open it up to conversation from everyone as to if there's any interest in someone serving as leadership for a Health Equity Champions subcommittee. And we can kind of take it from there. Or if there's any additional thoughts around opening a subcommittee for this group. And while everyone's thinking about it, I'll just mention, I know for some time we had module leaders. So we kind of had a vision of, if we did have a subcommittee chair, it would really be, the role would be someone that's just pushing this project along. We want to make sure that it's not held up, that we're able to make moves and bring it full circle and get it out into the community. So we have these 4 modules, just as a reminder, that we were focused on. And I do want to thank, I know a couple of members were able to send a little bit of feedback that they had about the module information. But I think what we need is just a community member that is going to take the charge to bring this home, representing the health equity work group. And in terms of a time commitment, again, we know everybody is extremely busy in this group, that we're all that you're all volunteers, and we appreciate any time that you can give. But I think it's as flexible as it needs to be. So I think there's just a couple of things that we want to check off so that we can move forward with our collaboration with the University of Maryland. So I'm going to stop talking and see if there's any additional feedback or volunteers. And if there are not any volunteers today, I can open up my email to any follow-up from this conversation.
Kim, I just want to mention Layla. Layla in the chat is interested.
Excellent. Thank you, Layla. Thanks so much.
Of course, I'm in transit right now, so it's a bit noisy in the background, but I would love to get involved, and can reach out offline about next steps.
Thank you. I appreciate it. Similarly, if you're not interested in taking a role as the subcommittee chair, but you really think that you or your organization would be a good person to take the lead on any of the modules, you can reach out as well.
Hi, this is Cynthia Bauer. I was going to say that I think Dr. Jackson and I were planning on reviewing, I forget, is it module 3 that's kind of considered the health literacy module? I forget which one.
It is module 2 that is very much based around the health literacy. Yep.
Yeah, I think Dr. Jackson and I were planning to review module 2 anyway, so.
Excellent.
Yes. Yeah, correct me if I'm wrong, Kim, but yes, that it was the module 2, I believe, that you shared, and only module 2, or was it module 1 and module 2?
So I believe we shared all of the modules with you more as a, to give it the health literacy overview as a whole. But for subject matter, it would be mainly focused on module 2.
Gotcha.
Okay.
Thank you.
So I'm volunteering Dr. Jackson and myself to do module 2.
To take the lead on module 2. Okay.
Yeah.
Thank you. And did I see another hand go up?
I mean, just based on the title, I haven't looked at module 3, but just the title kind of leads me to believe there might be some overlap between 2 and 3, but maybe not. So if there's somebody does volunteer for 3, we probably will be happy to kind of collaborate on that.
Thank you. And I think what we started to see is that we had consistency in the people that were providing feedback. So that making a subcommittee would just be a better opportunity to have a small group around this. So maybe I can do some individual follow-up and check in. I did get a little bit of feedback from some people, so maybe we can engage them as well. And I can send a separate check-in with everyone. But yes, please keep in mind, everyone, if you are interested in following up with this progress of the Health Equity Champions program, we do want to keep it moving, and we would love to have your help and feedback. Christine?
Yeah, for module 4, and it's been a while since I've dug in, that was more the specifics of like advocacy and things of that nature within Prince George's County and the state, right? So it's not promoting health and wellness from like a typical health view and lens, correct?
Correct. It was more
Okay,
of the
okay.
advocacy side, yes.
Okay, yeah.
And thank you. I saw that you can help with module 1. Great. Well, thank you all. I know this work has been ongoing for some time, so we want to make sure that we give it some attention and bring it full circle. All right, moving forward. So we do have some news on behalf of the entire Health Equity Work Group. I want to express my gratitude to Dr. Slade Martin. She's had so much dedication and leadership as our co-chair over the last couple of years, but she's made the decision to move on. Her efforts, her commitment, the passion has been such a driving force behind the collaboration and progress in addressing health disparities for this group. And even though you're stepping down from your role, your impact and all of your inspiration that you brought to the team will continue to guide us as we carry on this vital work of promoting health equity. So thank you so much, Dr. Slade Martin, for your contributions as a volunteer and a leader over the years. So I know she's having no voice today, so I don't want to put you on the spot to say anything, but I can read your chat for you.
Thank you. And if you could read my chat, I'd appreciate it. Thank you all very much.
Yes, and so Dr. Slade Martin says, thank you all for all you do to ensure health equity in Prince George's County. It has been my honor and pleasure to participate in the coalition and on the Health Equity Work Group in particular. Big thanks to Kim and Zuxacer for all you do. Health Equity Work Group is in good hands. And I know we have many partners that have been working with you over the years. So if anyone else wants to say anything, please use the opportunity.
It's been a long time that I've collaborated with you on this work group. So I definitely appreciate all of your work and just your overall passion for leading this group and for what you do. So thank you.
Thank you. Thank you.
We're going to miss you.
The same.
Oh, and I'm sorry I missed the beginning. I don't know why you don't have a voice, but I hope you feel okay.
I'm getting there. You know how I like to talk, but I just want to make sure at least you can clearly hear. Thank you.
I just wanted to say thank you as well. I think, Phyllis, you've put so much time and effort into keeping things moving along and connecting with the University of Maryland to bring a practical aspect to our module development. That I just really appreciate everything you've done, and I realize how much work you put into it. So thank you, and I hope you're going to continue with the work group.
You will see me occasionally. You will see me occasionally. Thank you. Thank you very much.
Right, and I think everyone should have Dr. Slade Martin's email address, but please feel free to continue sharing your love and support for her through email or chat. And for today, we'll just move on to our community announcements. I have a couple of other announcements to share, and then I'll open it up to the floor. Apologies, just having a technical. Dr. Sherman, are you on? She might not have been able to join. So, okay. So just wanted to share this event through the Hospice of Chesapeake Community Roundtable. It's on November 9th from 6 p.m. to 8 p.m. You can register now, and it's at Bowie State University Student Center. So there's more information on their site as well. And we'll be sure to share the link in the chat, and then it'll also be available in the slides. And then our next announcement is from our partners at MedStar Southern Maryland Hospital Center. They are in the process of completing their community health needs assessment, and they need some support and help. So you can participate in their 2024 community health needs assessment, and all of your responses will be confidential, but it will help them define their next steps in terms of community improvement planning. The survey is open until next Friday, October 27th at midnight. So you have the full week to get your responses in. And then just to remember to select MedStar Southern Maryland Hospital Center as the hospital for that you're completing the survey. Any other community announcements that you all would like to share? And thank you, Taylor, for putting those links in the chat. All right, our next Health Equity Workgroup meeting will be Thursday, November 16th. That's 1 week before Thanksgiving at 3:30 p.m. And then we have a save the date. Our next quarterly meeting is December 12th. We're working on making that an in-person, just finalizing the location now. So, you know, we want to make that meeting a very festive and happy event where we can just all come together and see each other. So I will keep everyone posted as we have more specific information available. And last call for any comments or feedback today.
I had a question for you. Is it too late to provide feedback on the modules? I remember getting it, and as I sometimes do, putting it aside and then forgetting about it. But I'd be happy to do it if it's not too late.
It is not too late. So last week we kind of threw around the idea of utilizing a rubric, but I felt like the rubric started getting a little bit more confusing than to just go through the module itself and provide feedback, because it started to become more structured. So I can certainly pass the links. They're housed in a Google Drive from the Terrapin think tank. So I can make sure to deliver the links to those modules in the meeting minutes. That way you can access those, and Sharon, I can directly send them to you as well.
Okay, that would be great.
Absolutely. We appreciate any feedback. All right. Well, thank you all so much. Enjoy the rest of your Thursday, and we appreciate your time and for joining today.
Thank you.
Everyone.